So over the next 15 minutes, we will talk about management of MetALD. I think we have already learned about disease spectrum and the burden and the interaction of the two risk factors. So we'll try and see how we can manage this entity. So none of these disclosures is relevant to the presentation. And so we'll talk about, I'll spend a couple of slides on diagnosis and risk stratification, talking about general treating the risk factors, and then focusing on alcohol use because of the sake of time. And then finally, we'll talk about liver and alcohol targets and metabolic targets for this particular disease. So quantifying alcohol use, and I think one of the challenges is because the new classification comes with pure volume and pure amount of alcohol use, and patients usually report in terms of drinks, which is not only variation from patient to patient, how they define their drink, and capturing that information and then converting it into grams of alcohol or pure amount of alcohol, which is also variable across the world. We know in terms of one particular drink equaling how much of alcohol. So there are a lot of layers and complexities in determining uh, uh, bucket the patient belongs to in terms of especially the meta-LD bucket. And the examples are here in terms of number of drinks you will use for MAS-LD, ALD, and MET-ALD, and you can see so much of overlap. Here comes the severe, which is metabolic metabolism of alcohol biomarker, which is phosphatidyl ethanol. Is a blood-based biomarker, as we all know, and can certainly discriminate a MET-ALD at a cutoff of about 20. And I think Luis is here, and his center has recently published a cutoff of 25. And below 200, you can segregate patients with MET-ALD. But we need to be careful because the patients have to be actively drinking in till the last 3 or 4 weeks to use this biomarker effectively. And also, what Robert, I think, elegantly pointed out, the changing disease state in this population. So once you recognize that MET-ALD population, risk stratification, this is important because you want to identify those who are at a higher risk of development of fibrosis and or advanced fibrosis. So we know from the MAS-LD world, the cutoffs are about 1.3 and 2.67 for FIB4, and the ALD cutoff is 3.25. For FibroScan or transient elastography, MAS-LD cutoff is about 8 and ALD cutoff about 12, I would say, for an advanced fibrosis. So, do we use the similar cutoffs for the MET-ALD, or which cutoff we take? And I think there have been some published literature, I may not show those slides, that the MES-LD cutoffs would work very well in terms of how you segregate these patients into the MET-ALD diagnosis. One of the slides I'm showing you here on the non-invasive testing, which is the gold standard was about the MRE, not the biopsy. And you will see the MES-LD risk stratification was 34%, MET-ALD about 6%, and ALD 3% in that population of about 8,000 patients in this Korean cohort, where the cutoff of 3.6 kilopascals of MR elastography was taken as the gold standard. And they could come up with a FIB4 area under the curve, if you take at a cutoff of 3.6, was fairly accurate in determining the diagnosis or advanced fibrosis in either of these cutoffs, in either of these cohorts or subtypes of steatotic liver disease. And you would see their sensitivity, specificity, and negative positive predictive values were similar to MES-LD. So I think this is one study where you can say that The MetALD cutoffs may be applicable to MetALD in terms of disease stratification and the risk of disease stratification. So when we talk about managing these patients with MetALD, in my mind, I think we are thinking about three particular areas or three pathologies in this patient. Obviously, alcohol intake, a disease of the liver disease, and a cardiometabolic risk factor. So I think there are three issues, and all three have to be addressed um, in terms of managing these patients more effectively. So talking about the general treatment of MetALD through the lifestyle intervention, controlling the metabolic risk factors, and as I mentioned, for the sake of time, we will not focus much on these nutrition and exercise. And the lifestyle intervention focusing on alcohol use is more relevant, I think, and I'll show you why I'm focusing on that. And then we'll talk about some of the medications focusing on alcohol use and maybe on metabolic control. So this is a study where we had an opportunity about 10 years ago to look at is alcohol-associated liver disease compared to NAFLD in this particular study. And I think there are other studies to show that when they present to the physician, they present at a much advanced stage when it is alcohol-related compared to when it is NAFLD. And they would see whether it is probability of cirrhosis development over time, probability of cancer, decompensation, and survival. So all worse in towards ALD compared to NAFLD. So not only they present advanced, they progress faster even after presentation. This is another nice study which is telling us that why the control of alcohol use is critical in patients with steatotic liver disease. And this is enhanced data set, which is a longitudinal data set to look at the outcomes and then specifying the cause of death in these patients. And you see these are MetALD cohort. You see, these are the MetALD cohorts, these are the MetALD and the ALD in this. So you would see the all-cause mortality. You would see twofold higher and much higher in the when alcohol comes into the risk factor compared to when it is purely MetALD. Another advantage of controlling and alcohol use, I think it may be hard for the patients to follow a specific diet style and a healthy diet and alcohol use at the same time. So if they have to pick up one of the two, I think alcohol should be picked up. From the previous slide, we learned that because alcohol damage to the liver is much more progressive compared to the metabolic risk factors, but also you are using empty calories. The average BMI of ALD patient nowadays is about 30 compared to like 30 years ago. And also the alcohol has a direct effect on cardiometabolic risk factors. So you, I think, can control just targeting alcohol use, all the triple pathologies of metabolic risk factors, alcohol, and the liver disease in these patients. Whether abstinence should be the goal when you already have a liver disease or cutting down to, say, alcohol use, I think is very nice study from Spain published last year in Journal of Hepatology. And I think this study makes me nervous when we talk to patients when they come with liver disease. And I have started becoming a little more upfront with these patients, telling them and showing this data to them is cutting back is no more a choice for you, especially if they're cirrhotic already. You should go cold turkey. And this particular study shows that even in the MetALD bucket, where the risk factor regarding alcohol use is the lowest amount of drinking, and when they subsegregate that alcohol use to very low, low, and moderate, you see the risk of fibrosis going up, even with one cardiometabolic risk factor, and that potentially goes up with number of cardiometabolic risk factors. So clearly, any level of alcohol use once you have liver disease may be dangerous in this or may be risky in this population. So how do you control alcohol use? Some of the medications, I'm not going to go into details here for the sake of time, but the FDA-approved medications, we don't use disulfiram in this group. Acamprosate and naltrexone are the ones. And the non-FDA approved, the most data is on baclofen, but gabapentin is also approved by American Psychiatry Association for treating alcohol use disorder in ALD patients. The other drugs are listed here, ondansetron, topiramate, and varenicline. And the problem with these drugs is not only that they have not been studied well in ALD population, but in my mind, I think even in those with no liver disease, it's not 100% efficacy for so many reasons related or unrelated to alcohol use. You need about 8 to 9, even for the best medication, which is acamprosate and naltrexone, you need 8 or 9 patients to drop down one patient to abstinence level. So clearly, we need more drugs and better drugs and repurposing of other drugs to see if they are effective in alcohol use control. Resmetirom is one medication which could be. This is the data from their Maestro-NASH trial where they looked at 10% of their population we accidentally MetALD came into the trial. And you look at the liver outcome improvement, similar whether they had MASLD and 75 patients who had MetALD. So this would be one drug probably can be studied in a more formal way. And we'll have the next talk coming by Madge talking about clinical trial designs. So maybe down the line, this is one particular drug which could be used. The other potential targets, what about MASH targets and the potential AUD targets? The GLP-1, FGF21, I think these are the two attractive ones for controlling alcohol use. And then there are several other targets like fecal matter transplantation. We have some emerging data. Metadoxine, we have LGG from our center has shown some data on controlling alcohol use. This is some of the cartoons showing you the dual and triple benefits of GLP-1 receptor agonists in terms of hepatoprotective action through multiple routes and multiple pathways. And this is the retrospective data set showing you the effect of GLP-1 agonists. You see this retrospective study on 153 patients. 46 did not use any of the GLP-1. Remaining used either semaglutide or tirzepatide. The control population before and after didn't change much. No statistical significant different change in alcohol use, but GLP-1 receptor agonists, both of them, as you can see, statistically significant change in alcohol use. And since then, not in ALD population, but in ALD world, there have been 3 randomized controlled trials on GLP-1. We know 2 have been positive, 1 has been negative. So the jury is still not out whether GLP-1 are the recommended drugs for alcohol use, but has a lot of potential and need larger trials to test that in the ALD population. Similarly, FGF21, and this is strong preclinical data, not only endogenous hepatic-derived FGF21, but also exogenously administered through the central mechanism through amygdala, causing in mice a significant reduction in alcohol use and making them sober and less preference for alcohol in the diet by the mice. And I think these have potential for treating alcohol use in MetALD population. And I think the studies are underway and some companies are showing interest. After the MASH trial in cirrhosis population, we recently saw an NEJM early this month. So the treatment of alcohol use disorder, the real world data is extremely poor. And we had the opportunity to study this in a more formal systematic review. And we were surprised when we reviewed this, and the paper is in press coming up. And outside the liver transplant setting, we had 14 studies close to about 100,000 patients, only 7 randomized controlled trials. And look at the pharmacotherapy, only 5. And look at the number of patients, only 300 patients. And the recipient, liver transplant recipients, is even worse. Only 1,600 patients have been studied formally with any therapy, and there have been no randomized controlled trial using medication in liver transplant recipients. A huge unmet need, and I think very optimally that we have a talk here on clinical trial designs in MetALD and ALD patients, which to finish and they meet this unmet need and huge gap in the patient management for MetALD and ALD. Summarizing, before I summarize, I want to show this alcohol-associated liver disease spectrum and how alcohol use plays out in MetALD and ALD population. Is the spectrum of liver disease can be early liver disease, we know, and it can be more advanced liver disease with compensated liver disease and decompensated liver disease and portal hypertension. And a subset of patients may develop alcoholic hepatitis or alcohol-associated hepatitis with a high risk of mortality and multi-organ failure. And if the patient goes in the wrong side of alcohol use, it can lead to negative outcomes, but it can also lead to positive outcomes if the patient stops drinking alcohol. So I think the most important in terms of what happens to the patient in long term is how the patient's alcohol use is targeted, which is so relevant in this population. So when it comes to treating, alcohol use should be the target when it is early disease, because we know that the patient outcomes and the survival matters when they are in more advanced disease. But when they are in more advanced disease, to help them recover from the acute phase, maybe the liver injury can be, but at the same time, I think in an integrated fashion, we should sooner than later start and think about alcohol use treatment also, so that we can improve in a holistic fashion and a more comprehensive fashion, the looking at the patient to look at their long-term outcome improvement. So I will summarize here with MetALD is emerging as a new disease, and then alcohol use should be the target for managing this subtype, and there are emerging targets, pharmacologic targets, not only to manage the liver disease, but also the alcohol use and the metabolic issues which are in these patients. So I will stop there. I know I wanted to share the data from Nicholas, who presented an excellent data on physical exercise, work-related or the leisure time related or more exertional or more physical activity which you are outside your work. But I think short of time, I could not show that slide to you. So I will stop there, and I'm sorry again that I had to hurriedly prepare these slides, and hopefully you liked it. So I will stop there. Thank you very much.